Good afternoon, everyone, on this very cold day. This is the Penguin monthly webinar for the Perinatal Mental Health Conditions Bundle. We're so excited that you all are here, and thank you for those who may be tuning in from school vacation week, and for those who may be traveling a little later, safe travels. We're glad you're here with us. So just our usual housekeeping items, please type your name and institution into the chat for attendance. Our optional share this month, if you'd like to share your favorite Valentine's Day candy and or self-care activity. I myself was indulging in the Reese's hearts and a massage last week for the holiday. Please mute yourselves when not speaking and feel free to type your questions into the chat during the webinar. We'll be able to take questions during the presentation as they come up, and we have a little bit of time afterwards to address questions as well. As always, the session's being recorded and we'll upload the recording with slides to our website soon afterwards. So we've had a little bit of a change in the agenda for today. We're still going to run through Penguin announcements and have our team presentation from Julie from Mount Auburn. But unfortunately, one of our presenters for today's psych emergencies presentation is ill and not able to make it. So we're working with that presenter duo to reschedule for another day because they've just done such a wonderful job preparing for the presentation that we wanted to provide it for you all exactly as it was planned and intended. So we'll hear from Mount Auburn, we'll go into our discussion, and then if we have some time back, we would really appreciate if you would take that time to do the bundle implementation feedback survey, and then feel free to take as much time back as you can after that. Speaking of that survey, this is our biannual implementation feedback survey. You heard me talk about it last month. The survey is open from February 5th to March 5th, and the goal of it is just to hear how the bundle is going so far for your teams. We have some questions about the onboarding process, how you're feeling about the participation requirements, any challenges with data submission, and the usefulness of the resources we've provided so far. So we're looking for the OB or RN champion for your team and the ambulatory champion, if you have one, to complete this survey. And then, of course, any other members of your team who want to share their feedback are welcome to as well. So we have a QR code here on the screen, and Brooke is also going to post the link in the chat for you all. We really take your responses seriously, and they're going to help shape the continuation of this bundle moving forward. So thanks in advance for your time. And thank you, as always, to all the hospitals joining us in implementing this important bundle. And big thanks as well to our bundle advisory work group who helps shape the content for these webinars and our resources behind the scenes. So we have a few announcements here for you today. As I shared last month, the Penguin team has decided to lengthen the implementation of this mental health bundle from September of this year to February of next year. We hope this comes as good news. This was based on feedback we'd already received from hospital teams about it's taking some time to get things up and running with various projects. So we have more time, which is great. The monthly webinars and data submission will continue. If you have any questions about what lengthening this bundle looks like, you can feel free to reach out to me or to Brooke. Earlier this month, Penguin got a request from the Massachusetts Department of Public Health to host a two-part webinar series that we called Bridging Borders, Understanding Healthcare and Maternity Care for Migrants from Mexico and Haiti. So for the first two Friday mornings of February, we had speakers with expert knowledge of the Mexican and Haitian healthcare systems come and share what they know and what guidance they could provide to us here in Massachusetts caring for migrants from these countries. So they're both very well attended and very helpful, and you can check out the recordings and the slides on our website. A few announcements from the state level. So DPH has come out with new guidance around syphilis screening. Prelim data at the start of 2024 indicated that there were 18 syphilis cases in the state, which was an increase of 29% compared to 2023. So DPH is encouraging clinicians to provide syphilis screening and inform all sexually active people about this risk. And you can read the full guidance in the links provided. DPH also wanted us to share that Mass Health has issued a standing order for prenatal vitamins and over-the-counter hormonal birth control. Both of these medications are covered by Mass Health and Health Safety Net, free of charge without a prescription. So please ensure that your patients are aware of both of these. We've also pleased to share that given recent updates to the CDC's website, Penguin is now sharing their resources on contraception and STI testing, so you can find those on our website for the time being. The Masspert TTA is offering their motivational interviewing course again. This is a 5-week virtual course, and the first session is February 24th, so next Monday, and runs through the end of March. So you can read the full training course description and click to apply. Hopefully there's some more seats available. If not, they offer this every couple months or so, so we'll be sure to keep you in the loop about future cohorts. Last month, I also shared that the Massachusetts Perinatal Team is looking for new members. This group is a consortium of Mass perinatal nurse leaders, and they meet to provide peer support to each other, collectively address emerging issues in perinatal care, provide input and feedback to MDPH on maternal and child health matters, and a variety of other things. They meet on the third Friday of each month, usually virtually, but sometimes in person, from 11 a.m. to 1 p.m. If you're interested in joining, you can email them at massperinatalteam@gmail.com. Lastly, for the state, we've been, promoting MCPAP for Moms resources and tools throughout this webinar series, but just wanted to highlight again that they are available and here to help. They have trainings and toolkits, telephone access to psychiatric consultations, and can help facilitate referrals to community resources. In addition, they can come to your hospital for grand rounds or work with you to offer a training with your affiliated OB practices. So if you're interested in either of those opportunities, you can contact Beth McGinn, and her email is here on the slide. Just two slides for national announcements before I turn it over to Julie. The Institute for Perinatal Quality Improvement is having their 28-day anti-racism challenge again this year. Even though it's February 18th, it is not too late to join. So you can register and you'll receive a daily email to reflect, learn, and act on your anti-racism journey. Those of you who may have already done this challenge, they update it every other year. So you'll see this is version 3, so they have new content for this year. So even if you've done it before, you may learn something new by doing it again. And finally, the Mama's Voices and AIM have collaborated to offer their community of learning on lived experience integration into QI. This is a 4-week program that will help healthcare providers better integrate patient and family partners into their QI work to improve maternal care. And that starts next Wednesday, February 26th, and runs through mid-March. Again, this is something that they offer every few months. So if there's not space left, there will be another cohort coming, and we'll be sure to share that when available. And with that, it's my pleasure to turn it over to Julie from Mount Auburn for their team presentation. Thanks, everybody.
Great. Thank you, Kelly. Thank you, everyone, for inviting me here, and I'm happy to be here today. My name is Julie Mann, and I am from Mount Auburn. I'm a midwife, and I'm also the Director of Obstetrics here at Mount Auburn Hospital. And I will be talking about the work that our perinatal mental health team has done over the past really almost year and a half to almost 2 years. And I see that some of my colleagues are here joining me. So Leslie McDonald and Natalia Carney, I'm going to call you out. And if you want to add to any of this, please do, because it really took a team to do this. Next slide. So if you're not familiar, Mount Auburn Hospital, it's a community hospital affiliated with the BILH network now. It was started in 1886. And we have a rather large obstetric department for a community hospital. We have 10 offices, OBGYN offices, and we do about 2,400 births a year. And we have about 18 doctors, 20 midwives, and 6 NPs giving care to our patients at our offices. And it's located right along the Charles River, a beautiful setting to have a birth. Next slide. And this is our patient demographic. So as you can see, the majority of our patients, 58%, are white non-Hispanic. And then about 18% are Hispanic, and about 13, almost 14% Asian, identify as Asian, and then about 4.2% as Black non-Hispanics, and the rest are either multiracial, prefer not to say, or unknown. And so that we've been looking a lot into our demographics and sort of looking at our outcomes too, which is part of our work in not only perinatal mental health, but also our racial justice and equity work as well. Next slide. So to start off our journey, we decided in about May of 2023 that we needed to really focus on perinatal mental health in our department. And next slide. And that came about mainly with the AIM bundle for perinatal mental health. We realized it was a gap, and then we saw this AIM bundle that was a guide, like a roadmap to how to even go about this gap, addressing this gap. And so we got together a multidisciplinary perinatal mental health working group with the goal to improve screening, treatment, and services around perinatal mental health. And as I said, we started in May of 2023 using this AIM bundle that I'm sure you all know of well as a roadmap. And then the working group we got together it was really important to us that it was multidisciplinary. So we have OBGYNs, midwives, nurses from the office, L&D and postpartum, our pediatric colleagues, and we did have 2 patient advocates that have since sort of slid off the radar. It was hard to keep them engaged, and it was really volunteer time, and that's something I'm going to point out throughout, things that we sort of want to work on and things that didn't go as smoothly as we wanted them to. But we did initially start out with 2 patient advocates as part of our group who were patients, former patients in our care, and then we reached out to these great organizations that are supporting all of this Penguin work, the MCPAP team and Penguin and Lifeline for Moms and UMass Chan Medical School to get advice and guidance. Next slide. So our first steps, we thought, where do we begin? And so we have a weekly grand rounds on Tuesday mornings at 8 a.m. for all staff members. And so we thought we can easily invite some speakers to highlight perinatal mental health. So we had Annie Lewis O'Connor, who is based at the Brigham, who has the CARE Clinic, which if you don't know about her or her clinic, it's amazing. It's based on trauma-informed care. And she came and talked to us about what is trauma-informed care and how can you embed it in your system. And then we had Dr. Rouge Kamal Haider, who I think has spoken many times at these events, who is the medical director of MCPAP. We invited her to come, and she talked to us about MCPAP services, and that was right when Zurzuvae just came out, and so talking to our team about that. And I saw that Kaylee in the announcements mentioned that MCPAP is willing to do that and come and talk about their services. And this is an example. They certainly were. And it was really helpful for us that they came to our grand rounds. And then we felt like one sort of easy win would be to reach out and collaborate more with our psychiatric department that we had here at Mount Auburn Hospital. We work very closely with our social work team, but there was a sort of gap between our psychiatric team and our OBGYN department. And so we thought we need to build that bridge. So we invited them to come and speak at grand rounds and to introduce themselves, to tell us about their services, how we can connect our patients to their services, and just learn together. Next slide, please. So that was our first steps. And then we felt like, okay, and again, this was on the roadmap for the AIM bundle. We thought we need to do a baseline assessment of where are we at? What are we doing well? What are we not doing well? And where should we focus our efforts? So we developed a 30 questionnaire survey that was focused on screening, patient education, knowledge of treatment, and resources and referral networks. And we sent that out to all of our staff, not only just doctors and midwives and NPs, but office staff, office managers, because we wanted everyone's input on this. And we got 94 responses, which was a pretty high response rate. And we found, next slide. We found things that we were doing well, but as we all sort of focus on things we could do better, the negative, we really wanted to improve on things that we saw areas and gaps to improve. So we found that we could really improve our mental health screening process. That our staff wanted more resources. They just felt helpless in the face of like caring for patients who really needed support. And so we felt like we could build a repository of resources for providers and staff and patients. And we also saw the need to have our resources be more inclusive. Most of our resources were in English, focused mainly on a specific population. We didn't have a lot for BIPOC, LGBTQ, mass health patients, non-English speakers. So we really wanted to think about that. And then we found that we could also really strengthen providers' knowledge and comfort in screening, treating, and monitoring. We found that very few providers felt comfortable in screening, mainly for depression and anxiety. But they, beyond the initial screening, like I think only like a few of them said that they actually started prescribing treatment. Once patients screened positive, they often looked elsewhere for someone to prescribe. And so we felt like, with the lack of providers for mental health, that we needed to sort of arm our providers with more knowledge to be able to start initial treatment for the patients that they were seeing. Next slide. And in addition to surveying, getting a baseline assessment of our staff members at Mount Auburn, we also wanted to get feedback from our patients. And so we did a small 15-question survey for our patients. For a 2-month period, they were distributed at offices at the 6-week visit in paper. And we wanted to know sort of how they felt our perinatal mental health services and support were. And next slide, please. So we got 159 responses, which again, we thought was a really good response rate for that time period. And we were very happy with the news we got there. We found that 95% felt comfortable discussing their mental health issues with our providers, that 84% felt that their health concerns were addressed, and that 99% were asked about their mood and emotional state in their pregnancy and postpartum period. Now, granted, there might have been some selection biases on those who filled out the forms, but this is what we got, and we felt that, okay, maybe on the patient end of things, we were doing somewhat of a good job, but we could do better, definitely with our staff. Next slide, please. So we dove in after our baseline assessment. Our perinatal mental health group, which I forgot to say, we meet monthly on a Tuesday morning for about an hour. And we developed the baseline assessment together, and then we issued it, we analyzed it together, and then we sort of made those step-by-step plans. And so we did the low-hanging fruit first. So we thought, okay, we can make our postpartum discharge instructions that every patient gets upon discharge from the hospital after delivery. We can make them better, and we can include more mental health resources. And so that's what we did. We edited the postpartum discharge instructions, added a lot more mental health resources, added mental health warning signs, and then we made sure that they were translated into our top languages of Spanish, Portuguese, and Haitian Creole. And then we educated our providers on how to make sure that every patient got these new discharge instructions through their EPIC discharge. Next slide, please. And then thinking about patient-facing resources, at that time, we were redesigning our website for Mount Auburn Hospital. And we had on there sort of information and resources for patients that was divided up into initial prenatal visit, 28-week visits, 36-week visit, and around the time of birth. And we felt like we needed another section called wellness and mental health. And so we built that section with a lot of the resources and links to other websites and other organizations for our patients. And so if you go on our website, you'll find this drop-down menu under pregnancy and birth called wellness and mental health. And these are just a few that you see on the screen, but I think there's like 20 or 25 different resources that we put there that our patients can go to and just sort of look at resources that they might not know about. Because I don't know about you, but there's so many resources out there that, it just is overwhelming when you need to find one. So we sort of vetted a lot of them and then put the main ones here. And again, a focus here you can sort of see is thinking about a diverse population, not only in sort of language, but gender identity and backgrounds. And so we have BIPOC resources, we have, resources for Mass Health Doula and things like that. And so we really, that was a constant focus throughout our resource development and our mental health group. And, if we're addressing one issue, is it addressing everyone equitably? Next slide, please. And then we built, this took probably about a year of our time, building a provider staff repository. And this is only internally facing. We built it on our portal, our internal portal for our team, our OBGYN team. And again, like I said, there's so many resources out there that we felt like we needed to vet and narrow it down so that when a provider or a nurse or any staff member identifies a need, that they could easily go to this repository and find some resources for patients. And this addresses, if you remember, that baseline assessment of we identified a gap that our team needed more resources and they wanted more places to go because they felt helpless at times. And so the resources are divided into these three sort of buckets. We have resources, screening tools, and treatment algorithms. And again, there's great algorithms and screening tools for treatment of depression, anxiety, suicidality, all of those things. But in the moment, they're hard to find. And so we gathered them in one place for our providers and put them there on the internal portal. And so in terms of the resources, these are just some of the buckets that we identified and put resources under, but finding a mental health provider, substance use resources, support groups, mental health crisis lines, social supports for food assistance, housing assistance, intimate partner violence, and then partner and family resources. One thing we did identify actually that I didn't pull out in the slide, but when we interviewed or surveyed patients, a lot of patients said, I felt really supported, but my partner did not. My partner needed help, and I didn't feel like there were those resources for my partner. So we have a resources that we identified for partners and families. I already said substance use resources. And then we did, again, we felt it was very important to identify population-specific resources. So we divided it into what are some resources that are specific to Spanish speakers, BIPOC, LGBTQ, Medicaid, and then younger parents. And so it's a really robust repository. And Natalia, if you're still on and available, do you want to sort of just briefly talk about how you use this? Sure, she's there. So Natalia is one of our labor and delivery nurses. And Natalia, oh, great. Do you want to just talk about a little bit how you use this resource?
Sure. Can everyone hear me?
Yeah.
Can Can you hear me? Okay. So this repository has been invaluable. I'm a labor and delivery nurse at Mount Auburn. I work with Julie, and I'm part of this perinatal mental health group. And I frequently work in triage where, part of my role is screening and intake for patients that present. And part of the screening is a social determinants of health screen, and patients that screen positive for food and housing insecurities, utilities insecurities. This repository has been invaluable in helping identify resources for these patients, specifically food banks, and I'm able to identify food pantries near where these patients live, and I've pulled up the address of these food pantries and showed patients on like MapQuest or Google Maps where the food pantry is located and how close it is to their homes, and printed it out and identified what days of the week they can go to which food pantry to get food, and translated it into their specific language. And patients are so grateful for this, and it's been really, really rewarding process. So it's really been a wonderful tool to use.
Thanks, Natalia.
Sure.
And we do have one and now soon to be two full-time perinatal social workers that support our team and see a lot of our patients. But what we also found out in the survey is that they are, and we knew this sort of anecdotally, that they're overwhelmed. There's just, the need is so great. And so we wanted to equip our team, like Natalia just said, with like, if you're just sitting with a patient, like you can help patients. You can also give them resources. It's not just like, oh, you have food insecurity, let me call the social worker. In an ideal world, like that would be a nice workflow, but the social workers have too much. And, at some point, like our team needed to fill in some of those gaps. And so we wanted to enable them to do that with this resource repository. Next slide, please. We also do, I'm not sure if all of you are CRICO hospitals, CRICO malpractice hospitals, but as part of CRICO, we need to do annual simulation training. And so we do a 4-hour annual multidisciplinary nurse, doctor, midwife OB simulation every year. And so this year we incorporated a perinatal mental health scenario into our OB simulation. So every single nurse, L&D nurse, and every single provider went through this together. And we had a patient who had a delivery and then came back postpartum into triage and had postpartum depression bordering on psychosis, concerns for psychosis, and sort of let our team sort of play that out and sort of to see how, did they know about our resources? How did they respond? What are hospital resources that they could use? How do they get a hold of psych? How do they get a hold of a crisis center? How might they go about getting a bed, a psychiatric bed? And so that was a really, really good exercise. And that's when we introduced and rolled out our repository online and familiarized everyone with that. Again, with the goal of not trying to make any of our OB team experts, but to provide them with resources so they don't feel so helpless, because they kept seeing it more and more and more patients in need of mental health resources. Next slide, please. And then we did mandate, actually, all of our providers to do the 2-hour online ACOG training addressing perinatal mental health conditions in obstetrics. And if you don't know about this, you should. And I highly, highly recommend that everyone does it. It's free. And it is excellent. And it's interactive. It's an interactive online learning platform. And it takes about 2 hours, and it really looks at screening, treatment, and then follow-up. And I have to be honest, like when we first, like I said, we did mandate it for all of our OBGYNs, midwives, and nurse practitioners. And there was a little grumbling, people saying like, well, I'm an OBGYN, I'm not a mental health specialist. Why do I have to do this? And then afterwards, people felt like they were thankful they felt like it was very, very helpful, and again, equipped them with more information to handle patients that are sitting in front of them. Next slide, please. And then we got to, so all of that, just to give you a timeline, all of that took a little over a year, maybe like 14, 16 months. So as you can see, this is an accelerated journey. And then we felt like, okay, now we've laid some groundwork. We've done some of the sort of the tasks that we had a lot more control over. And then we wanted to sort of address improving our screening of depression. And I know there's a lot of other screening tests but we thought we're going to start on the EPDS, the Edinburgh Postpartum Depression Screening Test. And then if we can standardize that across all of our offices, then we will, then follow suit with all the other screening tools. So we started on that. And at that time, that's when Penguin was starting their mini collaborative. And so we thought, great, let's do this journey with Penguin. So that started in May of 2024. Next slide. So we came up with the SMART objective for the EPDS that by September 1st of 2024, we wanted 50% of all of our patients at the Fresh Pond office, which is just one of our offices. We wanted to start small, and we knew we couldn't do it across all of our offices at once. So we thought, let's pilot it at one of our offices. So we wanted 50% of all of our patients at Fresh Pond office who are seen at their initial OB, 28-week visit, and 6-week visits to have documented EPDS. And, I think, as you probably already know, but the recommendation is at the minimum 3 screenings throughout the pregnancy, and 2 being in the pregnancy and at least 1 being in the postpartum period. So we wanted to focus and improve that. Next slide. Oh, no. I'm not sure why there's a block there.
I'm not sure either. Sorry about that, Julie.
That's okay. So what we did is we did a baseline assessment.
Let me see if I can remove it
Okay.
really quick. Sorry, everybody.
Well, while she's looking at that, because those are numbers I actually don't remember, so I can't even really talk about them. But while she's looking at that, any questions to a lot of that info I just gave you?
Oh, but it's still cut off. Weird.
Let's see if there's questions in the chat. There we go. Perfect. Thank you, Kelly. So we started off as, one should always what's our baseline? Like, where are we starting from? If we want to get to at least 50% of screening at these 3 visits, where are we now? And so we did a shout out to Leslie McDonald, who's on the call here. She looked at just 20 charts. And again, you have to make this doable. You can't, ideally, yes, would you want to look at all the charts during a certain amount of period? Yeah, but you can't. So we just picked 20, and she did some chart reviews on how many of those were getting screened at these 3 intervals. And so we saw here that we're at initial OB at the baseline, we were doing pretty well. 80% were getting EPDS screening. You can see 0% were in the at the baseline assessment. And again, pretty good at the 6-week postpartum, a 90%. So that's our baseline assessment. And next slide. So we did, and I'm not going to go through this all, but I'm not sure in your work with Penguin and in the bundle if you're doing any driver diagrams, but this was our driver diagram. And, it's just really helpful to map out sort of how do you want to do this? So, we have our goal over on the left, and then our primary actions needed to focus around like patients receiving the EPDS, patients completing the EPDS, and then providers actually reviewing and documenting. And then we mapped out sort of, okay, what are we going to do to make those happen? And I'm not sure about you, but there were issues that we identified in Epic, if you all use Epic, that, you know, the patients were getting the EPDS ahead of time in their like my chart and messages, and they were filling them out. Some were filling them out, some weren't. And then providers were telling us that, you know, they were getting them, but sometimes they would sit in their box for like a day or two. And we're like, oh, well, that's actually not good. Even though if it was a high EPDS number or that they answered positive to the thoughts of harm to self, it would flag it. But if the provider isn't checking the box every single day, which one should be, or having your box covered, it could go unnoticed. And we felt like that was a patient safety issue. And we were concerned about sort of that Epic use of the MyChart and the EPDS. So we thought that one thing we would do is make hard copies of the EPDS that patients would get at their check-in. So and then we wanted to make sure that the EPDS everyone knew how to get the EPDS in different languages. And that providers, we did some provider education around, you know, where do you document it and where do you document your actions and things like that. So this is our driver diagram, and I'm sure you'll get the slides and you can look at it further if you'd like. Next slide. So we decided, based on information that we had, that this was going to be our new workflow for the EPDS, that the medical assistants were going to room in the patient and give them the hard copy of the EPDS. And then the patient, while they were waiting for their provider to enter the room, would complete it. And that the provider would then review it in real time with the patient. And then provider would address any issues documented in the Epic. And then the MA afterwards would just scan that hard copy. And we also decided to tie the 28-week EPDS to the glucose testing, just so that the medical assistant could remember to put that hand in hand together. Next slide. And then we reviewed again. We did some chart reviews after we implemented that workflow for about a month. And we found that, you know, that initial OB, the EPDS was pretty high. We did increase the EPDS screening at the 28-week from 0 to 18%. And that we sort of maintained the 6-week EPDS screening. So we were headed in the right direction. So we looked at the charts. We also wanted to get feedback from our staff on how did that feel. Next slide. So we did a quick 2-question provider survey and a 1-question medical assistant survey. And we said, did you have enough time to complete the EPDS with your patient, or did your patient have enough time to complete the EPDS prior to entering the room? And most people said no, that it wasn't completed. And then we asked, did the provider have enough time to review and address the EPDS? And most of them said, yes, I did have enough time. Some said they didn't. The general feedback we got from providers was that it was often not finished when I entered the room, that the EPDS should be given at check-in so that they have enough time to fill it out. We should tie it to the glucose, and that positive screening, you know, it's all fast if everything's fine, but if there's a positive screening, that takes a lot of extra time. And then the medical assistant said they had no issues with it. It worked fine. Next slide. So we took that feedback. We did our second PDSA cycle and said, okay, we've gathered information, we've gathered data. Let's reiterate this process and see and incorporate that feedback. And so we said, okay, we're going to give people more time to fill it out. So then we asked the front desk to fill out, to hand out the hard copies of the EPDS so that there would be more time between when they arrived at the office to when they saw the provider. The patient completes the EPDS, the provider then reviews it, and the MA still scans it into Epic. We also talked to the chief of our department, if you could go back one, and said that, you know, can we, if there's a positive screening, or not, we're cramming a lot in the 28-week visit. So if providers want, can they schedule a 30-minute visit for that 28-week visit to address any needs? And if they screen negative, then you can spend more time counseling and educating. And the chair of our department is like, yes. And so we also sent out some information about how to bill better if they have a positive screen too, so that we could account for those extra visits. So that was our second workflow. Next slide. And then again, we measured, we did chart reviews, and as you can see, we're doing better. So in the chart reviews done after that second PDSA cycle, we're at 100% screening for initial OB. We've moved up now at 28 weeks to 40% screening, and at 6 weeks, we're still around 90%. And then next slide. We also interviewed again our providers and our medical assistant and front desk staff, and we didn't get many responses from the providers, but they still didn't think the patients had enough time, but they did have enough time to review and spend time with their patient. And then the front desk and medical assistants said that they had no problem with it. Next slide. And so, as you can see, we almost reach our goal, our SMART goal objective, that by September 2024, 50% of patients at this office who were seen at their initial OB 24 to 28 and 6-week visit would have documented EPDS. So that was our journey with Penguin in the Mini Collaborative. And that's sort of where we're at now. Next slide. I don't know if I've talked about, actually, so where we're at now, before I go on to lessons learned, is we're now rolling it out at all of our offices, this workflow. And we're currently gathering data and doing the same process. So it's like our PDSA cycle number 3, but we'll be collecting data from chart review data from all of our offices on these same metrics, and then also doing provider and staff surveys on how did it go. And then we need to decide as a team if we want to turn off the Epic option of the MyChart, automatically sending it to them. Next slide. So lessons learned, as you can see, it takes a lot of time. We started all of this in May of 2023 and have been meeting weekly, and sort of, this is there's still a lot more work to do, but I think we've done quite a bit, but it's been slow going. Multidisciplinary, if you're not already a multidisciplinary team working on this, I strongly recommend it. We've had great insight from all disciplines and all aspects of our department, whether it's postpartum nursing, L&D nursing, pediatric, all the voices are important. As I mentioned, the repository was a big, big win for us. It armed people with resources, which is what they wanted. Changes in Epic are challenging. We wanted to do some changes in Epic to work on like the EPDS, sending it out and things. That's all in the hands of IT, and and now that Epic is being rolled out in the BILH system, the changes are really slow. So that was a hard for us. And then I think the biggest impact actually of all of this work that we've done is it's just brought to the forefront perinatal mental health conditions. And I've heard from a lot of our team and providers, especially, is like, I'm screening more, I'm finding more people who need resources. I never have talked to psych before, and now I talk to them and I can get a patient an appointment. And so I think, that has been the biggest win so far, is just creating awareness and people putting it in the forefront of their care, and maybe not having all the answers for them in the moment, but slowly starting to give them more resources and ability to address it. I think that's it. Next slide. And you can't end any OB talk without a baby. So yeah, just wanted to thank you, and open to any questions.
Thank you so much, Julie. That was fantastic and an incredible amount of work, and just congratulations on everything that you and your team have accomplished so far. We do have a couple of questions in the chat for you that we'll start with, and if folks have any other questions, you can put them in the chat or raise your Zoom hand. So the first one from Kate is, can you talk about how you build better for the EPDS postpartum visits?
Sure. So, so I reached out to our billing team and mentioned to them that we were making these 30-minute visits, and then if they, if they were after screening, focus more on treatment coordination for behavioral health services, like what would be our billing. And so they gave me 3 different billing codes that and how to document. And I can share that with Kaylee and she can share it out. I don't remember them in the moment, but happy to share those. But it was really just a matter of like reaching out to our billing team and being like, okay, these might be extra long visits. How can we bill for them?
Yeah, Julie, if you send those to me, I'm happy to share out with the other teams on the call. That would be great.
Sure.
Wonderful. And then the second question from Grace is, were the resources you put in the repository and online known by someone in the practice already, or was there significant research that went into creating those?
I would say a little of both. So as I mentioned, we had 2 social workers, perinatal mental health or perinatal social workers that work with us, and one had an intern for a summer, and this is a great job for an intern. And they had this intern sort of put together a huge resource repository, and this was huge. I mean, like I said, like there's so many resources out there, so you do sort of have to hone it down or pare it down. And so she gave us everything that she collected, and then our team went through it and sort of pared it down to like, what's most applicable to our team within the community, and just pick maybe like the top 2 for each of the sort of subjects that we wanted to address or topics we wanted to address. So that's sort of how our journey went. And then if there were gaps, like if we didn't have any resources for certain population, like LGBTQ population, then we reached out to our providers and said, do you have any resources that we can put in this resource repository? Or we did some research on our own.
And I'll put a follow-up to that with a plug that Penguin has developed a toolkit for this bundle. Brooke has been working extremely hard on it over the last few months and gotten feedback from our work group members. And so we intended to put a slide in it about it on today's webinar, but we're still doing finishing touches. So we're going to share that with you all over email and post on our website too. And it does take an incredible amount of work to put together all these resources. There's no shortage of them, that's for sure. Thank you, Julie. Those are all the questions that I see in the chat. Does anybody else have a question they want to post or come off mute to ask? Oh, Sandra just commented that this is so helpful in supporting our structure for these screenings. Our hospital does an in-person pre-admission tour from 28 weeks on and will be screening in person.
Okay.
Thank you, Sandra.
And Leslie McDonald, I know you're on the call. I don't know if you wanted to add anything from our team.
No, I mean, I think you covered it all. It has been quite a long journey, but I think it's also felt like we've really made a difference. And that always feels good when you put in that amount of work to feel like it's you're making progress.
Absolutely. Thank you, Leslie. Sandra has a question. Do you see a benefit with in-person screening compared to written and handed in?
So I would say our screening is written. I mean, they get the hard copy, they fill it out independently, and then our provider just sort of looks at it. So they're not asking them the questions, and they're just reviewing it with them. And so I would say that compared to providers or patients just getting it electronically, we've haven't surveyed this formally, but we've heard from providers that they like it better when the patient gets it in the moment, for a few reasons. One, like if you have an initial OB and then you get it before you even meet the practice, those are some hard questions to answer before, personal questions, and you don't know where it's going or who it's going to. And so are you really getting honest answers, as opposed to like in the moment you're about to meet this person, they sit down with you and you talk about it. Providers have said that they feel like it is, they actually get, one, it's a point of connection and building trust, which is super important when you're caring for an individual. But that they felt like it was better patient care. And then also there was the piece of like, if it's sent, one thing we couldn't figure out in Epic is when is that sent in their MyChart? Like, is it sent a day before? Is it sent a week before? And this is where I was talking about the challenges of Epic. It's so hard to work with something you don't have complete control over. And so, if it was sent like, a week before their visit, there's a lot that could happen in that week, from when they filled it out to when they came in. And so are you really getting it in real time, the answers? And so we've heard, but we've also heard from some providers that they think like, oh, they don't have time for that, and it's great when it's done online before they even get there, and then they can just check. So I don't know, we hear a little bit of both. So but in terms of patient care, I think we're sort of feeling like the in-person, in the moment, real time is better.
Thank you. It looks like Sandra agrees. I hope that was helpful, Sandra. I think we'll pause for a few more seconds in case there are any last questions. Okay. Oh. Michelle says, would love to know what it is that you're looking to add for the postpartum documentation. Her hospital is in the BILH system as well.
Michelle, are you talking about our postpartum discharge instructions? If it's our postpartum discharge instructions, assessment screening tools. So postpartum documentation. So right now we're just using the EPDS in Epic, the tool there. And the only other tool we have, correct me if I'm wrong, Leslie, built into Epic is the 4 Ps for substance use. And so those are the only screening tools for perinatal mental health conditions that we have built in.
Yeah, and I think I was just going to say, I think the one thing that would be super helpful is to have a specific anxiety screening tool to use. We currently have the EPDS built in as a flow sheet. So it's easily accessible. The medical assistants transfer what's on paper into the flow sheet, but then that allows the provider to pull the result into their note and then document whatever they're going to document about it. And it's hard to know, like I know that some people use those 3 questions on the EPDS to screen for anxiety, but when it's all combined like that, and it's that's sort of a little bit of, in my mind, a cheat screen that tells you if those are positive, then you should do a full screen for anxiety. And we don't have that currently built in. So one, it's again, my gut feeling is that it's not being done, or not being done very frequently, even when those EPDS screening questions for anxiety are positive. And there's also really no way to document it. And so I think that would be one thing that would be very helpful. But right now we don't have the ability to change anything in our instance of Epic, because later this year we're going to join the larger BILH platform. And so I think that's something to think about for the future.
And I just put in the chat, I'm happy to email with anyone if they want, none of this is proprietary. We can share anything with you. So yeah, you can take a look at our patient-facing website about the mental health and wellness section, but we can, I'm happy to share a repository, any other information.
Thank you both. Great. I think with that we can wrap up for the day. Julie did put her email address in the chat, so if anyone would like to reach out to her with further questions, feel free to do that. Or if somehow you miss her email, feel free to reach out to me, and I'm also happy to connect you. So again, thank you all for joining during school vacation week. Our next webinar will be on March 18th at noon, and we'll be featuring a dual presentation on perinatal mental health treatment. We're very excited to replicate the kind of fireside chat format from the Penguin Summit in the fall, if folks were able to join that, with Dr. Nancy Byatt from MCPAP, as well as one of the patient representatives on the mental health work group. Brooke, could you go to the next slide? Nope, one back. There we go. Again, just want to plug this, the PMHC Bundle implementation feedback survey. This information it's very important to us. The survey is open until March 5th, and we'll be sending some email reminders after that. So since we can give you a few minutes back in your day, we hope you can get this started, and there is an opportunity to come back and finish it if you're not able to do it in one sitting. It should take about 20 minutes. And Brooke put the link in the chat as well. So with that, okay, so can you send out a new list of topics for each date? It seems these changed. You're right. Yes, things are shifting a little bit, so we can definitely resend the webinar schedule as it is at this moment. There may be more changes, but we'll keep you all updated. Thank you, Kate, for that reminder. All right. Thanks, everybody. Have a great rest of your week and stay warm.